But today, the focus of what we're going to talk about is on the technology intersection with health, and particularly how those things have changed as a result of our recent experience with COVID and remote working and that. So that's what we're going to talk about today. You know, I'm an old military lawyer, was an Air Force JAG for the auxiliary for 25 years. And so, you know, we always tell you what we're going to tell you, then we're going to tell you, then we're going to tell you what we told you. So first, we're going to talk about telemedicine in practice. Your experience in practice may be different. This is what my clients tell me it's like. Then we're going to talk about federal enforcement actions in the telehealth space, which is really important. This is how the government catches the cheaters. And then some remote working considerations for telehealth providers if we've got some time at the end of the presentation, because work from home is not what we're doing. What we're doing now is distributed workplace. You have a regular workplace. It doesn't happen to be in the box where everybody else works. That's your workplace. So it's not working from home. It's your company assigning you a workplace that's different from the office you used to work in. That means something legally. So we'll talk about that. Right, so when we're talking about telemedicine or telehealth in practice, there are three basic aspects. There's the professional aspect, which is how you actually practice medicine when you're not laying hands on people. There are state concepts that associate with that. There are federal concepts. Then there's how you get paid for providing healthcare and medicine, state and federal as well. And then how you use technology and integrate that into the practice. And patients and providers have different thoughts about how we want to incorporate technology. If you are both a haircut president and a client, in other words, you go to see your doctors remotely and you have providers in your space that are seeing patients remotely, you need to be thinking about this from your perspective as well as from your provider's perspective, because that makes a big difference in how you approach your task. So for professional practice considerations, how do you do it? There's lots of times now where we're practicing remote medicine, remote diagnostic medicine. We're talking to people on the phone. How are you feeling? How long have your symptoms occurred? When did this first start? Tell me what your fever is like. Tell me what your skin looks like, right? We're taking a history and physical without the benefit of being able to look at a real person. And we're making diagnostic choices based on that information. That is remote medicine. It just doesn't mean that you're staring at a screen or using Zoom or something like that. It's the same skill. It's the same skill. Are you practicing medicine when you do that? Well, your malpractice carrier and the licensing board probably say you are. So how then do you document that care? How do you document the patient's consent to your treatment? Well, if they're an existing patient on your service, that's simple. They've already signed all the pieces of paper, and you know how that works. But if they're a new patient, how do you do that? Right? If you don't have effective consent and you do something to, with, or for someone, you can still be sued for malpractice. You might not guarantee the right kind of documentation, so you might not get paid. You know, are you giving medical advice when you're not licensed as a physician or some other person that's entitled to give advice to patients, right? Patients always want an answer. They always want something. But if you, as the person talking to the patient, can't give them the answer, can't answer that question, can't do what they want you to do, and you have to go get another provider, well, don't overextend yourself. I mean, you probably took a long time to get the license that you have. Finally, the most important thing to remember is you can't get a patient to sign a document that says you can commit malpractice on them and agree not to sue them. That's against the public policy of everybody. And so don't try. Don't try to create the moral obligation. Courts really hate it. Plaintiffs' lawyers really love it when you try to do that because then you get to write a check. Now let's think about practicing medicine if the patient is not located in the same state that you are in. This bedevils every physician who has a patient call when they're on vacation and says, hey, doc, you know that problem I was trying to manage? Well, it's come back and I need you to call something into the Publix pharmacy in blankety blank, Florida, so I can run by and pick up a prescription. Well, Used to be, we didn't think much about that as providers because we're providing continuing care for a patient that's already enrolled on our service. What does Florida's medical board say about you doing that? Well, if you do that a lot, maybe you need to find out the answer to that question. We know that the Florida Medical Board takes a dim view of doctors in New York prescribing drugs for patients who winter in Florida if they're not licensed in Florida, right? But we don't know whether that's a continuing practice, an individualized practice, whatever it is, right? Then to add to the crazy quilt of regulation, you have every different type of license having different rules. So whether you're a physician, a PA, a nurse practitioner, clinical social worker, dietitian, nurse, psychologist, pharmacist, right? Every state has its own rules governing how you are licensed and what you can do within the scope of that license. For example, I practice in Florida. Florida says that in order to supervise a nurse practitioner or a PA, you have to be physically located as a doctor within 35 miles of the practice location where that person practices. Georgia doesn't have that requirement. Georgia says you can only supervise a certain number, but they don't put a geographic limit, right? Florida says you have to be within a certain geographic distance. And every state's got different rules. So you need to know what those rules are. You may have to have insurance that is from an insurer that's qualified to do business in the state where the patient is located. And sometimes you don't. For example, if you're a provider that has a very, very narrow scope of practice and you buy your malpractice insurance through your national professional association, you might be licensed. That insurer may be authorized to deliver policies in every state. On the other hand, if you're in a single state, you buy something from a single state provider, or hey, you're one of those forward-thinking people that belongs to an insurance consortium or a private label insurance, you might not have an insurance license or be qualified in another state. You need to know, because some states are really finicky. So that's the kind of thing we don't think about when we let Dr. Jones practice from home, and he's decided home is going to be the Isle of Palms rather than Lake Lanier, right? That's a big difference, because now we're here in 2 states. Just to think about it. How's about when the patient is in a different place than you are? Patient calls a primary care physician as an inpatient at another hospital, asking to do a video visit. Well, you don't have privileges at that hospital. How's that going to work? Right? How about somebody that's going on vacation? They're coming here because they're not going to get shot at in most places. So they want to come here. They finally get their COVID pass and they get to come to the United States and they get sick. Well, you can treat them while they're here, but can you treat them as a follow-up there? Can you interact with them in that place? If they're inside the European Union, you might not be able to without having to comply with the GDPR rules about data transfer and ownership and all that kind of stuff. Have you thought about that? Well, Disney's thought about that. Disney doesn't send data overseas. They give it to the patient in hard copy when they go to the Sand Lake Regional Medical Center after they come from the first aid station at Disney World. And you're on your own, isn't it, Jack? Because they don't want to get involved in all that stuff. Well, what about you? Have you thought about that? We don't know. How about your license? During the public health emergency, you don't have to be licensed in the state where the patient is located, as long as you have a good license anywhere. In other words, they're treating other people like they were federal employees. Federal doctor doesn't have to be licensed in the state where he practices because the government's sitting there. There are tons of guys practicing at the Naval Air Station Hospital in Pensacola, Florida, that are licensed in some place other than Florida because they don't need one. Same thing with the VA and places like that. What about when this is all over? Pausing for effect. We don't know. We don't know. We don't know whether the federal government has the authority to tell a state licensing board that they can't make you have a license. So we don't know. Now, how about this? You are one of those people that employs folk from another land, and they went home during the pandemic to take care of their family, and now they can't come back because they're on the red list and they can't travel. Can they see their patients here when they're stuck there? Well, we don't know. We don't know. You have to look at your own human resources policies for starters, right? Are you considering that location a location where they're practicing medicine? It's rare, but not a zero risk decision that a state board would expect you to be licensed at practicing in their state, right? Internationally may not be quite as crazy, but we know there are some states in the United States that don't allow any remote medicine from a licensure standpoint. The only reason it's happening now is because of the public health emergency. What happens when we go back to those rules? What about if that person lives there and works there, they have a bank account there, all that kind of stuff? Do you have to have workers' compensation insurance there? Can that state collect taxes? We know that New York and New Jersey and some of the other confiscatory jurisdictions are trying to take money from our friends because they are living there during this time. Hey, they punish doctors that volunteered to come up to New York and treat the COVID epidemic, and then they left, and New York sent them an income tax bill for the money they earned while they were in New York. So what's to keep other states from saying, well, you lived at Hilton Head Island during the pandemic and worked from there, you owe South Carolina insurance, income tax, even though you're technically a Georgia resident, right? How about that? What about if you're providing stuff from a different location and your Medicare contractor's different? Right? If that location is a location, you have to update your 855B and put that location in there, then you've got to go talk to that Medicare contractor in that location. See, I don't know the answers to these questions, but these are things that need to be thought about when you're making these kinds of decisions, right? And then we go back to the question of, does your malpractice coverage cover you? Is that insurer licensed to do business in that state? If you get a claim from a patient in that state, are you going to get coverage? You don't know. You need to ask that question. It's a crazy quilt. If you've never seen a crazy quilt, this is a crazy quilt. It's just like this. Imagine that these are all the states, and you see how different they are. They're kind of the same. Some of them are the same color. Some of them have similar patterns, but they're not exactly the same. Well, welcome to the modern practice of remote diagnostic medicine. It's kind of like that. Now, let's make it even harder. Prescribing. You want to give that person a drug. Forget everything you think you know about all those prescription ED medication commercials that you see on late night television when you ought to be in bed and not watching late night television. Just forget that stuff. Forget that stuff, okay? Look at this rule. The federal rule requires that a practitioner perform at least one in-person medical exam of a new patient prior to prescribing a controlled substance. During the public health emergency, there's a waiver as long as it's something that you usually do for a legitimate medical purpose, and you use an audio-visual, real-time, two-way interactive communication system. And you otherwise comply with the rules that are set up in the states that govern this and any federal exceptions that apply during the public health emergency. That's a lot of ifs, right? So legitimate medical purpose by a practitioner acting in the usual course of the practitioner's profession. This does not let you dabble. If you are an orthopedic surgeon, you don't prescribe drugs that psychiatrists prescribe just for a patient convenience. I can tell you from personal experience, doctors that do people a favor outside of their area of treatment get in trouble when something that person does goes south, because the feds are looking for somebody to blame, and guess what? It's set up. If that patient's in another state than you are, you really need to know how this works. For example, if you use non-physician providers in your practice, each state may have a different rule on what kinds of prescriptions those people can utter in the course of treating someone. So you need to know the answer to that question before you turn them loose on that patient. All right, so enough about documenting the care and getting your license right. Let's talk about the money. You need to know what a covered service is. And you need to know that by looking at the rules that you have for what defines a covered service. This means who can provide the covered service, what documentation you're required to demonstrate that it was a covered service. Do you have to supervise somebody at a particular level of supervision? Is it general supervision? Is it direct personal supervision? If I'm saying words you don't know what they mean, that's probably not so good. Is it incident to a physician service? Well, if it's a new patient and a nurse practitioner sees them, how can you bill up? Right? There's a 15% difference between what the physician can bill and what a nurse practitioner can bill. You can't bill up if it's not incident to a physician service. And in some states and in some payers, you never can bill incident to if the person's separately licensable under Medicaid. Georgia's one of those places. You can't bill a nurse practitioner incident to a physician service. For Medicaid purposes, you have to bill the NP. So you lose 15% every time you have that encounter. Well, you might just say, oh, this is too hard. I'll just not bill for it. Well, maybe you can and maybe you can't. Private payer contracts require you to bill for something that's a covered service if you know that that person is covered. If they're a brand new patient and you don't have a copy of their card with the company that's got a color in their name, you might be able to get away with billing the patient directly. But if you know that they've got that insurance, your provider agreement, unless it's different from the 9 that I've looked at before, says you have to bill for that service. Why? Because they want to know what costs are being incurred, because they have arrangements with certain providers to give them some money if they keep their costs down, right? You also can't lead with, hey, we know this is telemedicine, so we're not going to bill you for it. Because, oh, thanks, doc. By the way, I've got this really expensive treatment I want you to do for me. Well, you can bill for that, right? We don't want it to be considered an inducement to refer or a kickback. So you cannot routinely waive copays. Finally, just to throw this gasoline on the fire, if you don't bill for a copay and you tell the patient up front you're not intending to bill for the copay to decrease the inconvenience associated with the televisit, that itself is probably health insurance fraud in many states, including Georgia. So, have I scared you off completely? If not, here's some more good stuff, right? How about the difference between a new and an established patient? We've already talked about the fact that if a nurse practitioner sees a new patient, there's no possible way you'll be able to create that encounter as incident to a physician service, so you have to bill at the 15% haircut. In some states, there also is a limitation that physician assistants cannot see new patients first. They have to be seen by a physician who establishes a plan of care, and then they can be seen by a PA to implement the plan of care. That used to be the rule in Georgia, by the way, but it's still the rule in other places. So you need to know which other places you might be doing this kind of stuff. How's about if the person is a patient and they express suicidal or homicidal ideations? How do you get law enforcement to go to that place? Can you even do that in that state? You know, can you send somebody to collect them if they're saying, I have these problems, I'm really thinking about doing harm to myself? Can you do that? Can you require as a condition of your practice that you don't do mental health visits unless the patient is attended by somebody who can hear your otherwise confidential communications? If you do that, do you have a piece of paper that the person has signed saying that's okay? Because I've been in lawsuits where people have shared information with a person they thought was a family member, but they never got consent to share the information, and then it blew back. So you have to think about how you document the care. Think about the notion of documenting the care in the old-fashioned way. If the person was sitting in your office and you're having that conversation with them, what pieces of paper would you have them sign? Just because they're looking at you on a screen doesn't mean it's any different. If you ask me a question on this screen and you want my legal opinion about something, I have to tell you I'm not your lawyer, you need to sign an engagement letter. Otherwise, I can create a reasonable likelihood that you think I'm giving you legal advice. Just because we're doing it this way doesn't make that dynamic any different. The technology doesn't change the process from a legal and compliance standpoint. That's the problem. We just said? Advance the slide.
I think it wants to go in more depth.
Yeah, somebody, it looks like we're frozen because that mouse at me. Well, I can vamp.
I'm sorry.
So what we're then going to talk about is
If you'll just let me just, for our virtual guests, I'm gonna stop the screen share for a second to see if I can get us back up and running, all right?
we're going to hit a hammer. We're going to get it with a hammer. See what we can do. So notice that we're talking about a lot of different kinds of risks, right? Ordinarily, when you're in a regular practice environment, you have pieces of paper that your lawyer or your insurance company or your professional association have said, these are the things you need to get your patient to sign, right? If we're taking a picture, if we're letting the patient take a picture of that spot on their butt and text it to you and say, is this cancer? You need to be very careful about giving them any kind of advice. Because what you're then doing, most likely, according to the malpractice lawsuit people and your insurance license people, is all malpractice, okay? Now, let's talk about some technology. Right now, it's not a HIPAA violation to use a non-secure platform, like this one. However, we also know, I can't get this to change. Can you advance the slide?
Yes.
All right.
I just need to.
We may have to do this a different way, gang. The FBI, even after taking time out for investigating the people that rioted at the Capitol and all the other stuff that they're busy doing, they even noticed that there was an uptick in cybercrime associated with the health industry segment. And so when you're using non-secure technology to do this kind of thing, don't think that the bad guys aren't snooping, because they are. Okay? You also have the problem, go back. You also have the problem, we'll have to do it this way.
Yeah, I'm afraid so.
Okay. We also have the problem that Zoom and Skype and FaceTime and Teams and all those systems are not integrated into our electronic medical record systems. So how do we document? Ordinarily, we're writing stuff down. We're typing stuff, right? We're documenting that encounter. When we do the history and physical, what's your chief complaint in your own words? And then we go through the rest of the drill. We're documenting stuff. But we're not recording these video conferences. If we are recording these video conferences and you haven't told the patient you're recording these video conferences, oh boy, that's a different problem. But then how do you store that and integrate that into the medical record? Because if you use that encounter to diagnose, treat, or manage the patient's condition, in Georgia, that's considered part of your official patient record. So how do you do that, right? We also know that you can't waive the interpreter requirements. So if you're speaking to somebody and English isn't their primary language, you still have to offer them an interpreter if you have to offer an interpreter in the first instance, right? That means hospitals and physician practices are owned by hospitals. There's also no waiver of any other privacy rules when using waived technology. So you still have to maintain the privacy and security of the data, right? You download that encounter and you load it into your EMR. That all has to maintain the same kind of end-to-end security that you need to make sure that you comply with the HIPAA security rule, not the privacy rule. Totally different, okay? Now, here's another little interesting problem. I know you don't like to get calls all the time reminding you that you have a warranty on your car that's about to expire, or that you'd like to get a lower rate on your MasterCard, or any of the other things that people want to use to fraudulently obtain your personal protected financial information. information. So if you're like me, you block calls from numbers you don't know. Well, if you're a physician and you've had an encounter with a patient, they have to call you in an emergency, and you gave them your cell phone number, but you didn't unblock them, how do you do that? Is it malpractice? You kind of gave your patients a way to contact you to work around the fact that you're not in the office. Well, now what? Right? Now what? So you have to think about these kinds of issues.
Hey,
Okay?
see, I just.
See, when demonstrated, this is Murphy's Law, when demonstrated for the repairman, the device will work perfectly. All right, so now we're going to talk about how the cheaters are cheating and how they're getting caught. No, you need to stay. Because apparently your magnetic arm is making this work.
I got nothing else.
Okay, wow, I'm going to tell your boss. So look at this. Telemedicine and durable medical equipment marketing, $1.2 billion in cheating. 80 search warrants in 17 different federal districts. What they did, they got people and telemarketing companies to get older folk to sell braces and stuff like that. So the physician wrote an order after they talked to the beneficiary on the phone. There was no doctor-patient relationship. There's no documentation of a history of physical, no nothing. It just checks the box, right? All that the DME provider wanted was a certificate of medical necessity. So the doctor was signing those and handing them out like candy at Halloween. And so the providers, the DME companies, and the owners of the telemedicine companies all got individually indicted. Okay? So what does that say about this? The quantum of information you need to establish legitimate patient care hasn't changed just because we're doing this telemedically, right? You still have to do a history and physical. You still have to document the medical necessity for the therapeutic intervention. You can't just sign a certificate of medical necessity and that be the only thing in your chart. The government's going to think you're cheating. Because what? Because most likely you're cheating, that's all. Okay, now how about this? This was just straight not providing care. This is just not providing care. The provider was giving prescriptions and DME referrals in exchange for cash. So the doctor was claiming to provide telemedicine services, but really they weren't. All they were doing was submitting bills and sending referrals and then getting a piece of the action back from the referee. So individual indictments. $3 million of fraudulent claims. If it's got 2 commas in the number, the feds are going to come for you. Don't make any mistake about it. Same kind of thing. $200 million forfeiture of assets, pled guilty to international money laundering, $424 million conspiracy to fraud Medicare. Yeah, they're going to the cookie. So this was it's a compounding prescription fraud, okay? So the physician worked for a telemedicine company that prescribed compounded medications to TRICARE beneficiaries, okay? So what happened here is the provider sent invalid prescriptions to the pharmacy. Now look how this works. The pharmacy filled invalid prescriptions. Therefore, when the pharmacy submitted the reimbursement request to Medicare, that was fraudulent because there was no legitimate medical need for the drug to be dispensed. Now do you see why they're going after Walmart with the opioid thing? No pharmacist should have known that it was okay to prescribe 6,000 doses of this drug to somebody. They can't simply say, like the Nazis did, I'm just following the doctor's orders. The government is saying, if you pharmacy submit a prescription that is facially, or you ought to think no, facially invalid, we're going to come after everybody. Now they got the doctor for $300,000 worth of stuff, and he had to do the perk walk civilly. Doesn't mean he's not going to get prosecuted criminally. This is just the civil penalty. Right? Doesn't say what the medical board's going to do in Connecticut. Doesn't say what the DEA is going to do. The DEA can independently come and take his provider's prescribing ticket, in which case he's out of the doctor business, right? They don't care. I'm telling you, having been in the room with those people, they don't care. You can say, how about we just let him not prescribe category 2 narcotics, and he can still write prescriptions for other stuff? They say, nope. If we don't trust him to write a prescription, we don't trust him to write any prescription. And he's out of the doctor business once he can't write scripts. How about this one? $2.1 billion. This is laboratory referrals, paying people for laboratory, genetic testing, laboratory referrals. Again, telemedicine, telemarketing, right? They charged the individual medical providers who were involved in this, 35 different people. They went against the genetic testing companies with administrative action. Administrative action is the polite way to say you're not in Medicare anymore. And for most people, that's the NCAA death penalty. If you can't bill Medicare, you're out of business, right? I mean, how many people that provide skilled nursing care can survive not being able to bill Part A? How many people that do ambulances are going to survive if they can't bill Part B? Nobody. Nobody. You're just not going to stay in business. Telemedicine pharmacy fraud, $931 million in fraudulent prescriptions. And look at how, I want you to know how this works. FDA, Postal Service, FBI, Homeland Security, US Marshals, everybody sits in a room. I've been in this room. It's off of Peachtree Street, and they all sit in a room and they all talk about everybody that they're going to go after, and they pile on. So it's not just the medical board that's coming after you. Once the medical board gets their teeth in you, they're going to tell all their friends on this list, and they're all going to come get you. Which is why a pharmacist in Camilla, Georgia can get 83 federal felony indictments, because they just pound you. This is more braces, telemedicine, $56 million. So to recap, the government agencies, the 3-letter agencies, the TLAs, which is a 3-letter thing, it's just kind of cool. They talk to each other and they talk across state lines. Once they get you for one thing, they look for other things because they're pursuing the entire supply chain, up and downstream. Because of the Yates memo, individual people have to be charged. There's no more company paying a settlement and pounding their employees behind closed doors. Nope, real people have to do the perp walk because they're not going to let companies shield their executives from criminal culpability. Okay? The last bullet point is really important for everyone. You're so small, you're not going to get caught. Nope, that's not how it works. If your practice is a 2-doctor practice, but you happen to contract with the big criminal who's cheating everywhere else, you're going to get swept up into it too. I just had this conversation with the assistant U.S. attorney in the Northern District of Georgia talking about healthcare targets. They want to get the individual practitioners because then they will rat out the people up the food chain. They will put the pressure on you. Don't think it's just the big guys they're after. No, they want all the rats on the sinking ship. All right, now, just quickly, because I know I got to rush, I want to talk about some remote working considerations. This one is a big one. Just because you're doing stuff from home in a public health emergency doesn't mean that all the HIPAA rules don't mean anything. It's just the ones that relate to the use of certain types of video technology to provide telemedicine consultations. And that's just so you don't have to have a business associate agreement with Zoom. You still have to secure the data, you still have to protect the PHI, you still have to do all those things. It's just that little tiny piece of it that you get a pass through. But we don't know how long that's going to last. So you need to be thinking about engineering a solution that will persist beyond the public health emergency. And if you can't get a business associate agreement with Zoom, maybe you don't use Zoom. This is why it's important. 4 years ago, these are the numbers. 61% of data breach victims were companies with less than 1,000 employees. I betcha you're a company with less than 1,000 employees. 65% of companies have over 500 employees who have never changed their passwords. You need to fix that. You can fix that with your software. You can make people change their password. 95% of data breaches have caused attributed to human error. Oh, blank, I clicked on the wrong button. Or, oh, blank, I replied to all on Word. Or, oh, blank, I taped my password under my keyboard and somebody found it. Yep, that's you. That's you right there. This is the FBI public service announcement I was telling you about. As early as April of last year, when all the crazy started happening, cyber actors take advantage of COVID-19 to exploit increased use of virtual environments. Nothing's changed, y'all. It's just gotten more persistent and more deliberate. In the month following the national shutdown, 1,200 COVID scam complaints from the FBI. In a month. And of course, we all know the problem Zoom had with people bombing into rooms and not being able to be forward or click in, and somebody clicks in and the passwords are not unique and that kind of stuff. So just because you got a Hipaa pass for Zoom doesn't mean you need to not be asking Zoom hard questions like, hey, just have you fixed this problem? And every other video platform that you use, you need to be asking those same questions. While you're in the public health emergency and you've got some top cover from the feds, go ahead and start laying the groundwork now for fixing the system. The Defense Research Institute, which is the defense lawyers in the insurance industry, will tell you, with my permission, they will let me tell you with their permission, that you need to have a shield against the people that are attacking you, and that shield is cybersecurity insurance. However, if you haven't looked at what the coverage requirements for your cybersecurity insurance are, you may have a bunch of uncovered liabilities. For example, if your policy says you have to maintain a certain level of virus protection with certain types of software that have been approved by them, and you don't have that, and that's what causes the breach, you may not have any insurance. If you decide to pay ransomware to unlock your data set and you don't notify federal authorities, I know, for example, one policy of Lloyd's of London will not reimburse you for the ransom because they insist that you involve the federal authorities before you make the decision to pay some payment. So you have to read your policy. If you don't have anybody that knows how to read a policy, you need to find somebody who knows how to read a policy. You need to secure your wireless router. That means you need to have a password. The password does not need to be lowercase p password. It also doesn't need to be uppercase P password with an exclamation point. Do something dynamic. You need to have a firewall. You know how hard it is to find a free icon that says firewall? This is the only one I could find. See, it's a wall with fire behind it. That's the best you can do because I didn't want to pay a licensing fee. But you need to have a firewall, and you need to have all the bricks in the firewall checked regularly and updated regularly. Having one that's not updated is just about, don't do that. Just update your stuff. Most legacy systems cease to be supported at some point, at which point they become vulnerable. Let me tell you. Having been in a class at Georgia Tech where we hacked a Windows 97 Service Pack 1 computer in less than 5 minutes to get access to its entire hard drive is kind of cool. But if I can do it, and I'm an old guy, the young guys that are spending their time in their mom's basement, they can do it a lot faster, and they're going to get all your stuff. So make sure you update your software, including your firewall and security stuff. You also need to have authentication and role-based authentication and authorization. In other words, what we're saying here is only the people that need to have access to a particular data set need to have access to that data set. In your business, you have people move from job to job to job. If you're a larger organization, you have people promoted, move laterally, right? When they move out of a particular job description, they may or may not need to have access to the data that they used to have. And they need to have new access to data that they didn't have before. When you're provisioning with them with access to data, don't just throw another data stack on top. Re-provision their data access as if they're a new hire. And look at what they need to have for that job. Don't let them carry their data rights from job to job inside the organization. Reissue them as if they're a new hire. That way you can cut off a lot of the lateral movement that criminals can do in getting access to a single person's data set. This is very important. And multi-factor authentication is very important. If you're as old as I am, you remember Get Smart and the cone of silence that used to descend over Get Smart and Chief when they were talking, and then they couldn't hear each other, and so they had to take it off again. Well, this is the cone of silence. Try to maintain some mystery about the conversations you have with people. Don't yell at each other in the hallway where people can hear what you're talking about. Don't do the same thing virtually either. Don't reply to all. Don't send data on people in emails unless you do it through a secure email portal. If you have to do it, pick up the phone and talk to them in an old-fashioned way. Remember, the telephone company doesn't keep any of this data unless you're the subject of a federal wiretap. So the conduit exception to Hipaa applies, right? Any persistent form of data transfer is going to be governed by the PHI rules. But telephone conversations won't. So just talk to the person. Don't go poking around in the data set just because you have the desire to know. In other words, don't surf your data. And don't shoulder surf other people. Don't come up behind them and ask them to use their password to get you information that you're not entitled to. And employers, don't let your employees do that kind of thing. Don't download stuff onto your computer that's not authorized by your IT department. Look, just because your employer or you as the employer have decided to let people work from home using technology they bought for themselves, doesn't mean that your data protection policies don't need to apply. If your rule says you can't download unauthorized software on our computers, guess what? You need to get the employee to understand that their computer is not your computer. Unless you buy them a computer and say you have to use this for work. And then you take the ISP address of the IP address of that computer and you make it a trusted device so that only that computer can access your data. And then you have this rule, don't put stuff on my computer. This is where lots of problems happen, right? The clickbait. I want to find out what George Clooney's wife is doing now. Click. Well, some malware from some guy or some gal in some other country is tagging along with that download, and now they're looking at your credit card data. Why would you do that? You have to physically secure your computer. I can't tell you how many times people have been fined by the federal government for letting somebody put active patient data on a laptop that is then lost or stolen. Why are we still doing this? Why do we still let people download active patient data to a portable device? If it gets lost, you have to assume that all of that data is compromised, which means you have to go through this rigmarole, patient notification, and all the optics are bad, and the reputational injury associated with it, not to mention the fact you've got to pay people. Just don't let people download active data. Use all the computers as dumb terminals. They just go into the cloud or they go into the data set and they access the data and they make the change there. And you can't ever download a file. You just have to change how you do business. It's not the same thing. Hey, Alexa, commit a privacy violation for me. Well, there's 2 lawsuits right now about that very thing. The transitory data that Alexa stores creates a privacy violation if it's used in a healthcare environment because Alexa is listening for the words, hey, Alexa, or hey, Google. And so it stores this transitory, this ephemeral data. Unfortunately, Google and Amazon and all those people didn't tell you that some of that data still lives out there in the universe. And if you're having a conversation with your doctor because he's too lazy to write it down himself or have a scribe come in and wants to use Google, and he didn't get your consent to that, there's a bunch of people in Washington and California that want to know your name because they want to put you in a class action lawsuit. So why would you ever want something like that in a medical practice? I have no idea. Mm-hmm. And then let's think about this. If you work from home because your employer said you have to work from home, And they say, and you've got to go to this place and go to this at this time and do this thing. And you have to use your personal vehicle because we don't provide you with a car. And on your way to do that thing at that place that your employer says you have to do from your home, you clobber somebody with your car. Who's at fault? Whose insurance company? Does your employer have automobile insurance for worker driving? If you're the employer, do you have these kinds of arrangements with your employees? Do you know? Have you talked to your insurance company about that? What if the employee gets hurt? Do they have a workers' comp injury? You were doing something that they told you, they were doing what you told them to do in their car when they got clobbered. They have a workers' comp injury? Is it going to touch your workers' comp policy? Did you have that covered as a location on your policy? Did you have workers' comp insurance? Did you not know that that person was your statutory employee? This is the part where you're saying to yourself, oh boy, we better get some answers to these questions, because now that you have 900 different locations, if you're a big company and everybody works from their home, and that's their designated place of work, does your commercial general liability insurance cover that? Does it cover the loss of data at that place? If you provide them with a laptop and it gets stolen, does your insurance company recognize that loss? Will they pay you? See, it's just not the same anymore. We have to stop looking at people working from home as a temporary convenience to something where we've distributed our workplace all over the country. And if that's what we've done, how does our insurance work with that distribution? Hugely, hugely important to move the insurance. All right? That's a lot of information to suck in there. You've got my email information there. You've got my office cell phone number. I'd be glad to talk with you about this offline if you want to talk about that you don't want anybody else to know about, or if we've got some time left in our time together, I'm glad to answer some questions.
Yeah, I was gonna say, we do have a few minutes left for questions or conversation. Barry, I wanted to check with you and be sure that it would be cool for us to send out your slide deck to folks today so that they can have your contact information.
Yeah, sure.
At least distribute your contact information for that very purpose.
Just so you know that it's all copyrighted, and you can't send it to your friends and neighbors. You can use it. Try not to use the images, because either we bought licenses for them or they're public domain images, but you have to be careful about forwarding images to people if you don't know what the provenance is.
Kind of used to Firewall.
Yeah, the Firewall one's okay. That one's yeah, that's just, like I said, I really struggle to find Firewall. But yeah, so just have to be careful when you do this kind of stuff.
Yep. Good information, by the way.
So what questions do we have?
So one I have is how, Humana and we have United Healthcare, and they offer these telehealth. You got an app on your phone, and you press on something and a doctor pops up, and how are they able to do that?
Well, they've gotten to have answered all these questions.
Yeah.
I'll give you an example of this because this will make sense to you. So if you've got one of those insurance companies that makes you get maintenance meds by mail order, because most of them do, right? So let's say I'm that guy and I send off some maintenance medication to this pharmacy, and the maintenance medication comes back, and I'll see a set of initials on that prescription label. Okay. Having checked with lots of pharmacies that do this, the initials are the pharmacist that is licensed in my state. So the mail order pharmacy has a pharmacist that's licensed in my state to dispense that drug, and they mail it to me after a pharmacist that's licensed in my state reviews that prescription, as if it happened here, right? It happened on Eagle Parkway in Fort Worth, Texas, but it's as if it happened right down the street, okay? So people that are doing telemedicine consults, if they're doing it in the public health emergency, they're not thinking about what you just asked, which is how can you do that? Before the public health emergency, in a lot of states, the answer is you can't do that. Because that encounter occurs outside of the state where the physician is licensed, and there's no state exception for remote diagnostic medicine for if you're a new patient or fill the blank, right? All the checklist items that we talked about. Now people are doing it because they can do it without having to think about it. My job is to say, hey, Dan, if you want this business model to persist, like everybody thinks that you want it to persist, you have to start doing this stuff now. And so many people are not doing this stuff now because it's too hard or because they know they can't.
Yeah, I remember.
So they're just riding the wave.
Yeah, before the pandemic, I remember my previous company had our health insurance. It was like a private health company that just hit an app and a doctor would pop up and I'm going, how does that work today? I mean, it doesn't seem like a viable business model.
Well, it could be,
Yeah.
but you have to
You
do
got
this.
millions in loss.
You have to do this. Look, and I set up an international telemedicine consortium. I tell you how the blocking and tackling works. So we had a United Kingdom occupational medicine clinic. They wanted to treat injured workers on site outside the National Health Service because they could do it faster, they get back to work faster, and they wouldn't lose their productivity. That was insured by an Israeli insurance company. These guys, because they didn't want it to have anything to do with National Health Service, they had to contract with UNC Chapel Hill and Stanford University and Wake Forest University, Bowman Gray School of Medicine, to have radiologists do the reads for the x-rays, right? Well, we had to balance all that because they're, where's that patient? If I access that image in North Carolina, am I considering that a North Carolina patient? Or are they a UK patient? Or are they a visitor? See, now it'd be almost impossible to do that if the UK was still in the GDPR. Because, right? So the rules are crazy quilt still have these problems we have to sort through. And if you don't sort through them, then as soon as the public health emergency goes in, everything's going to contract. I represent a client in another state where they just flat told all their doctors that were on their medical visas that were working on their visa programs, if you go home, you can't work. We're just not going to let you access our database from overseas, and we're not going to let you treat patients because we don't want to figure out how we can get paid for it, and we don't want to do it for free. So you want to go home and take care of your parents, that's great, you're off the paper. Take a leave of absence, whatever it is, but you're not treating patients. So, you have to touch all the bases. And when you've seen one deal, you've seen one deal because the state laws fit into different puzzle pieces and all the rules are different. So that's why we can make a really effective list of questions. That's just the start. Then we have to go find the answers.